Well, first of all, I would like to thank the organizers for the opportunity to speak about eosinophilic esophagitis. Thank you.
Okay.
Well, first of all, I would like to thank the organizers for the opportunity to speak about eosinophilic esophagitis, how to identify the culprit food. My name is Terreehost. I am a staff member of the ENT department of the Amsterdam University Medical Centers, and I work there as an allergist. First of all, I would like to declare that I have no conflict of interest in relation to this presentation. When we look at eosinophilic esophagitis, although it's a relatively new disease, it came only into prominence in the late 90s of the last century. It is now one of the most prevalent inflammatory bowel diseases. And a recent study by Dellen in 2015 estimated the prevalence up to 1 person per 1,000 persons nowadays. In the definition, it says that there is an eosinophilic inflammation of more than 15 eosinophils per high power field, and it has to be accompanied by certain clinical symptoms, such as dysphagia, but also retrosternal chest pain or pyrosis or food impaction. Of course, in children, it can be much less clear because they don't want to eat, they have failure to thrive, or there's growth retardation. One of the first things that was very clear is that there was a high coincidence of allergic comorbidity, as was described by González Cervera in 2017. When you have eosinophilic esophagitis, the odds ratio of having renal conjunctivitis is 5, for asthma it is 3, and for atopic dermatitis 2.8. So nowadays it is considered one of the diseases of the atopic syndrome. The treatment of eosinophilic esophagitis, as described recently in a very good article by Shehad and Aceves in Yaki in Practice, is dedicated to symptom reduction, to inflammation reduction, and hopefully the prevention of strictures. And in the latest guidelines, when we talk about therapy, we talk about either pharmacological therapy or dietary elimination therapy. When you start pharmacological therapy, it is nowadays custom to start with a proton pump inhibitor for 8 weeks to check the esophagus by endoscopy and biopsies to see whether the inflammation has reduced and the patient is responding to therapy with clinical symptoms as well. If not, then there's the topical corticosteroids, which are now available in many countries. And as a latest option, many biologicals are now in research setting available or even already recognized by the authorities. Another option, like I said, is the dietary elimination therapy by means of elemental diet, the 6-food elimination diet, 4 food, 2 food, or even 1 food, which many patients actually prefer. Why would you choose medication? Well, arguments in favor of medication, it takes very little effort. You just take a tablet or inhalant steroids in case of topical steroids, or even the tablet, which is nowadays available. It's not as time-consuming as keeping to a diet. Very important, there's much less need for endoscopies. You start a therapy, you do your follow-up, and if the patient is responding, you have an endoscopy every year to see if the patient is still in remission. And there's, especially in corticosteroids, a very good response, up to 90%. When it comes to the cons, the argument against medication, well, for proton pump inhibitors, it's not effective in all patients. Both in children and adults, there's a good response in between 40 to 50% of the patients. And during therapy, people can actually relapse. The same is true for topical steroids. Under treatment, people can relapse, and up to 15% get candidiasis, which of course is easily treatable, but still 15% get a problem with that. And as of today, we are still not sure what the long-term effects are of topical steroids. Of course, we know from from allergic rhinitis that local therapy in the form of nasal sprays do not give a lot of side effects, but still we are not sure yet. One of the reasons why we still use diets is diets work. In the early 90s, there was a first article in children using an elemental diet with only 1 or 2 foods. And even from then, when we use the normal elemental diet, it has about a 90% histologic disease remission. The problem with the elemental diet, it's unpalatable. I tried it once, it's not good. 6-food elimination also has a very good histological response in both children and adults. Same goes for 4-food elimination, and there's still a reasonable histological response in both children and adults when you use only the 2-food elimination diet. So just to remind you a little bit, and I would like to ask you to think back about your dinner and your breakfast, your dinner yesterday evening and your breakfast this morning. When you look at those diets, the 2-food is milk and wheat. The 4-food, milk, wheat, egg, soy, but also legumes. The 6-food even if also includes the tree nuts, fish, and shellfish. So when you look at the practical part of that diet, and you think about your own dinner and your breakfast, well, for me, that would have meant that I would have no breakfast this morning. So when it comes to the problems with these diets, it's quite hard to maintain. And while we first use the top-down method, where you start with a 6-food diet and you reintroduce certain foods, we now prefer the bottom-up, where you start with a 1-food or a 2-food diet, and if it doesn't work, you move to 4-food and 6-food diet. And dietitians actually assure me that it's easier to have people leave things from the diet more and more. It's easier to do than have them implement a 6-food diet at the very beginning. Now, I already told you one argument not in favor of the diet. It's very hard to maintain. But another problem with diet is it can be very costly. If you have to replace all the foods which you are not allowed, it can actually mean that you have to pay more for your food. When you have also IgE-related symptoms, oral allergy, urticaria, up to anaphylaxis, and you have to implement that diet as well as a 6-food diet, it could leave you with very little to eat indeed and run the risk of deficiencies. Furthermore, while you need only 2 endoscopies if you're lucky and a yearly check when you use medication, when you do a diet and reintroduction, it requires an endoscopy after every introduction to see whether you are still in remission. Not for adults, but very true for young children, when they are just learning to eat, to learn to taste, to handle different foods, and you give them a very intensive diet, it actually hampers the development of feeding skills in young children. And also very important, both for children and adults, when you have such a restricted diet, it can have a very big impact on both your social and your professional life. So why would you stick to a diet? Well, if you have milk or wheat or both, It could be that a patient says, for me, it's very easy to maintain. You need no medication. And actually, people can feel more empowered because they have influence over their own disease. Nevertheless, starting with a 2, a 4, a 6 food diet or an elemental diet may not be what we would like. What we would like is that we can predict which food is actually causing the symptoms in our eosinophilic esophagitis patients. And various tests have been used in these patients to see whether they could predict the culprit food. The skin prick tests for IgE-mediated symptoms, the atopy patch test, which of course is more dedicated to delayed type reactions, specific IgE in serum, and even the ISAC. Now, there was a very nice review written by Arias, one of the main researchers in this field, which appeared in Gastroenterology in 2014, where he did a review of the skin tests, which included both a skin prick test and a patch tests. And what you can see that while in the earlier studies by Sifiakos and Diakouros et al., that there was actually a very nice result. In the later studies, the result of skin prick test and atopy patch test were much less good. And that can be in previous studies, there was the symptoms related score that was used and not always histological response. But still, the result is not as good as we hoped. In the end, you are in about 0.5 positive predictive value of these tests. And when you look a little bit further at the studies of Jonathan Spergel, he had a very nice research published in 2002 where he used the skin prick test and the atopy patch test to have an allergy test directed diet, where he could achieve a clinical and histological remission of 49%, which is actually pretty good. He did an update in 2012, where he reached a 53% remission. But, and that's a very big but, when he excluded milk, regardless of the result of the skin test or the atopy patch test, he achieved a remission rate of 77%. So apparently, at least the tests for milk do not give a good prediction for the result of a diet. And another big disadvantage of both studies is that it was symptom relapse that was used as a parameter and not histological response. So what are the results in general of both the skin prick test and the atopy patch test? Well, as you can see, while the positive predictive value varies between 26.3 and 86.3%, on average, there's a 47% positive predictive value of the skin test. The negative predictive value is much better. But again, when you look at one of the most important allergens in EOE, for cow's milk, it varies between 30 and 44%. A little bit better for soy, egg, and wheat in various studies. Then again, maybe you have to remember that, for instance, when you have pollen allergic patients, they can easily show a positive test for wheat as well. So, do the patch tests actually do any better? No. Again, on average, 44%. In general, negative predictive value, 90%. Cow's milk, 31%. When you use a combination, for the positive predictive value, the combination of skin prick test and patch test, again, around 44%. For cow's milk, the negative prediction predictive value is about 44%. Is it then any better in specific IgE in serum and the ISAC test? Well, no. There was a study done in the AMC in 2012 and 2013, which was published in Allergy a year later by Van Rijn of the gastroenterology department, where they used an ISAC-directed allergy diet. And in the first 15 patients, the results were so bad that the study was actually stopped. And the same is true for other studies that use specific IgE in serum. The predictive value is not good. So why is it? Why do allergy tests fail to identify the culprit food? Are we perhaps, like this photographer, looking in the wrong direction? Well, of course, you could say perhaps it's the quality of the extracts, because we all know that when you use, for instance, extracts of fruits or vegetables by industry, the quality can vary a lot, and fresh products are actually performing better than industry-produced extracts. Like I already said, it could also be that we have a lot of false positives due to pollen sensitization. When you are birch pollen or grass pollen positive and you have actually rhinoconjunctivitis, hay fever, you can get positive results for many foods without them being clinically relevant. But maybe more importantly, and this is what we have already seen in, for instance, atopic dermatitis, the fact that a diet works doesn't prove that the mechanism, it just proves the role of food. Many patients, for instance, complain that their atopic dermatitis is caused by food and that the diet works. Of course, we also all know the studies that when you actually do provocations test double blind, that the food may not be so important after all. But again, also in eosinophilic esophagitis, even when you have a positive test or a negative test, you still have to prove that the role of the role of the food, that it actually causes the symptoms, or in fact, alternately, is safe to eat. So another argument that perhaps IgE is not as important as we really hoped it would be is proven by the use of anti-IgE, omalizumab. There was one study, an open-label, non-randomized study in 15 adults, which showed some positive results, that it was well tolerated. There was a histological response and a clinical response. But a later study in 30 patients, placebo-controlled, where they used, this is a bit hard to interpret, but what was used is a schedule with both the weight and the amount of IgE, and the normal amount of omalizumab was about 300 milligrams, so what we also use in, for instance, urticaria or severe asthma. And that didn't show any result at all, not histologically, not clinically. And one study actually had an open label follow-up again, and not even a third of the patients actually responded to the omalizumab. On the other hand, when you look at ongoing studies and published studies with dupilumab, you can actually see that there is a clinical response and a histological response. So the Th2 response is actually responsible for the complaints in EoE. So, summarizing, IgE apparently plays a minor role. We do know that the pathophysiology of EoE shows a Th2 pattern, perhaps, again, we should take a different look at things. And what we did in the AMC is that we considered a few things. We have an inflammation that is restricted to the esophagus, which bears similarity to local allergic rhinitis, where you do not have a response in the skin prick test, not a response in the blood, but when you actually do provocation tests in the nose, you see that people respond, which was shown in a very nice research by Carmen Rondon from Spain. We know that there is similarity to atopic eczema because both diseases have barrier dysfunction, Th2 response. But when you get to my age, you also remember the older literature. And in this case, I remembered that we actually already had some studies that showed that you could have a local reaction to food allergen in the gastrointestinal tract. In 1997, there was a study published by Bischoff where she could show that when you did a skin prick test in a bowel with food allergens, that you could actually get a local response, which correlated with the foods that people had gastrointestinal symptoms to. A follow-up study in 2012 with BET-V1, the major allergen of birch pollen, in people with hay fever showed that patients with hay fever actually had a positive response in the colon on BET-V1, skin prick test with BET-V1, while controls showed no response at all. And not from the food allergy, but from drug allergy, we also know the fixed drug eruption, where you do an atopy patch test on normal skin, which shows no result. But when you do it on the place where the fixed drugs eruption took place, you actually can get a positive result. And that's how we came to develop another test, which was a food allergy test in the esophagus itself, locally, but we also took biopsies for later incubation with foods. And the results of this test were published 3 years ago in Gastroenterology. This was the thesis work of Marijn Warners. And what we did is we took an endoscope, which is normally used for people with esophagovaritis. We developed allergen tests for the esophagus, and we had people with active eosinophilic esophagitis as well and controls to do this test. We did at least milk, wheat, and either egg or soy. We took the patient's personal history to see whether there were any foods that gave that the patient suspected were causing them symptoms. And of course, we took some controls, which you also do with your normal skin prick test, namely the histamine and sodium chlorine. We had a schedule where we did the skin prick test on predefined places in the esophagus, 12 o'clock, 6 o'clock, but also 3 o'clock and 9 o'clock. And we looked 20 minutes after the injection, but also 24 hours later, because we expected a similar mechanism as in atopic dermatitis with just a late response. Patients first followed a 4-week dietary treatment, either a 6-food diet or an elemental diet. They were given skin prick tests, and we did serum IgE for a predefined amount of allergens. Then they did the gastroscopy with a minimum of 3 predefined allergen extracts and maximum 3 of the suspected food allergens by the patients. We did the endoscopy, we took images, we took biopsies, although not on the spot of the prick test itself. And as I said, we came back 24 hours later to look at the results. The patients that participate in the study, this was, as I should have said before, a proof of principle study, so not a double-blind placebo-controlled trial where we had a diet based on these tests. It was a proof of principle to see whether the test was actually viable. 8 EOE patients participating, main age 49 years, a little less concomitant atopic disease than in general, because normally it's about 70 to 80%, 25 with still active disease, a few in the rest in remission, 38 treated with an elemental diet, and 3 adult healthy controls. And what you can see when we looked at the delayed response to the esophageal prick test is that you here see a very nice response to wheat, and here a very nice response to peach, and also a very small one to the diluted histamine. And when you look at all 8 patients, you see something very remarkable. You see here the results of the skin prick test and the serum IgE, and here the results of the suspected food. Now, patient number 1 suspected peach to cause symptoms. And actually, while it was not visible in the skin prick test or the serum IgE, it was visible in the esophageal prick test. The same for walnuts, but then again, the patient also suspected yogurt. It came up in serum IgE, but not in the esophageal prick test. But when you look in general, and these were all the foods that patients reacted to, both in their clinical history and in the esophageal prick test, you see that we picked up more allergens than in general with the skin prick test or the serum IgE. So that was for us very remarkable. And also, when I may draw your attention to patient number 5, what you see here, that patient number 5, who had no suspected food, he was positive to sesame, soy, and wheat, nothing in the esophageal prick test. What our patients did tell us, and that was also very remarkable because we weren't aware of it before, is that certain foods cause them painful or at least unpleasant retrosternal sensation, which was very different from what we used to call oral allergy and is now called the food pollen allergy related symptoms, and also different from dysphagia. They described it as, I take a bite from an apple and it's like my esophagus is cramping. I feel my esophagus reacting when I could be still chewing the apple and only have swallowed a little bit. And a recent study by Bredenoord, which was published in Allergy, which was an interview study under patients and medical specialists, showed that there are actually far more people suffering from these symptoms than we suspected before. And what I didn't tell you, and I have to go back now to the previous, while the peach and the walnut were food allergen tests that came up after 24 hours, we saw a very good reaction to the soy and the banana and the hazelnuts within not even 20 minutes. And I would like you to show the video now, because it surprised us a bit, I can tell you. This was the first patient who got an injection with the food. And what happened is that within minutes, you see the swelling of the esophagus, which was so intense that the endoscope couldn't pass anymore. Well, the first time that happened, that shook us a little bit, with very good effect on our heart rate and our blood pressure. It also disappeared within 20 minutes, so it is a very short-lived reaction, and you see that 24 hours later the swelling has gone completely. And actually, of the 8 patients that we did this test with, 5 showed this reaction. So this, I've seen this film a few times before, and it's still very impressive to see. So what we probably caught with this research, with this test, was an actual view of what we now call FIRE, food-induced immediate response of the esophagus. Probably, likely, maybe this is still an IgE-mediated response. Perhaps we stimulate the mast cells and the basophils that are present in the esophagus, but there's still much more work to be done before we can see what actually happens there. Now, I also told you that there was ex vivo stimulation of the biopsies that were taken at the time of the esophageal prick test. And perhaps you saw the poster last EACI, where they did biopsies in 12 patients with the eosinophilic esophagitis, as well as 6 controls. Unfortunately, I do not have the data myself. They are in Utrecht. But when you look at the poster, you saw a very nice increase of both IL-5 and IL-9 in only the EOE patients with the clinical suspected foods, while the controls showed no increase in IL-9 or IL-5 at all. So is this just our finding? No, it's not. Because not too long ago, in 2018, Antonella Cianferroni, also another well-known researcher in this area, published an article in the Annals of Allergy, Asthma and Clinical Immunology, where she showed the results of peripheral blood PBMCs that she incubated with milk allergens. And this was a study done in 20 children with a proven milk-induced eosinophilic esophagitis. So the children were put on a diet, the esophagus improved, and when they reintroduced milk, there was a relapse of the symptoms, and they did the same test in 8 controls as well. Children were negative, there was negative specific IgE to milk. And when they incubated the PBMCs with milk antigens, the caseins, lactalbumin, and lactoglobulins, inclusive negative control, but also a positive control to make sure that the peripheral T cells were actually reacting, they got this result. And these are the controls. So what you need to look at is A and C. And what you see is when you stimulate the PBMCs in controls, there's no increase at all. When you do this in EOE patients with inactive disease, you see a significant rise in the activity of the T cells. When you do it in children with active EOE, you also see an increase. And actually, the increase in inactive disease was even relatively higher than in active disease, probably because the T cells are already stimulated. So, what does this mean? Well, in conclusion, what I would like to hope you get from this lecture is that diets work, but are very hard to maintain in the long term. As dedicated as you are as a patient to keep to your diet. Allergy test-directed diets so far have proven very disappointing. They fail to identify the culprit food. So as for diets, we are for the moment stuck with either the 1 food, 2 food, 4 food, 6 food diet, or in case of very severe disease and when it comes to possible deficiencies, elemental diets. But, and that is something that I will hope will come up in literature in the nearby future, when you do ex vivo stimulation, either with peripheral T cells or with biopsies, we may be able to predict the eliciting foods much better than with our allergy test directed diets. And lastly, it's a very new syndrome within the EOE, but when you go back to your clinical practice, please do ask your patients about the fire symptoms, because apparently they are suffering much more from it than we, for the moment, know. And with this, I would like to end my lecture and thank you for your attention.